Welcome to Oncology Data Advisor, featuring our continued coverage of the 2025 ASCO annual meeting. Today's guest is Dr. Abigail Zamorano, who is an assistant professor in the Department of Gynecologic Oncology at McGovern Medical School of UT Health Houston. At ASCO, she presented a poster titled Caregiver Distress, Caring for Those Who Care for Our Patients. And today she's here to tell us some more about this work. Dr. Zamorano, thanks so much for coming on today.
Thank you so much for having me.
Absolutely. To start off, would you like to introduce yourself and share a little bit about what you do?
Sure. I am Abigail Zamorano, as you said. I am Assistant Professor of Gynecologic Oncology at UT Health Houston. So I'm a gynecologic cancer surgeon. I manage gynecologic cancers, including the diagnosis and care of uterine, cervical, vulvar, ovarian, and fallopian tube cancer. In this, I take care of many, many patients, both in surgery as well as with chemotherapy. And what led to this work that I will talk about is noting that so many of our patients rely on other people during the course of their treatment to make it through their treatment. We refer to those people as caregivers. And we have been struck, I have been struck by the role that caregivers play in the treatment course of our patients. And the fact that we don't have specific questionnaires or ways of evaluating the distress or lack thereof of our caregivers to make sure that they are able to give the best care to our patients.
Absolutely, very important topic to delve into. So looking forward to hearing some more about this presentation. So for background for it, what are some of the unique stressors that caregivers face when helping the patients they're helping take care of go through treatment?
So we focused just on patients who were undergoing a new treatment of chemotherapy. So most patients were undergoing chemotherapy for the first time. So caregivers' roles will change depending on what treatment their patient is receiving. But for our purposes, for chemotherapy for our cancers is typically given every 3 weeks. That means that patients have to come into the hospital or to clinic every 3 weeks. Their caregivers are usually the ones responsible for bringing them into their clinic visits. They're also the ones responsible for getting them home, as well as getting them to all of their imaging. So transportation is a big issue. Then at home, the caregivers are assisting patients taking their medications. Chemotherapy can be very nausea-inducing, and so the caregivers are helping the patients remember to take all their anti-nausea medicines on a schedule. They're also paying attention to the patient's symptoms and helping the patients to decide when they need to call the care team to either ask for help or ask more questions. Then if you think about the toll, the tax that chemotherapy treatment has on a patient, it can make them feel very fatigued, weak, not able to do many of their normal activities around the house. This means that for a lot of caregivers, these tasks now fall onto them. So they're the ones preparing meals, cleaning up around the house, also doing things like paying bills. If the patient was also the caregiver for others, like say they have young children or older family members or even friends that they were taking care of, sometimes this now falls as an additional duty to the caregivers. So for all of these reasons, these caregivers are vital to allowing a patient to proceed through their treatment the best that they can, because they're really taking on a lot of the responsibilities that the patient had.
Absolutely. Thank you for the overview. Definitely a lot of unique considerations. So I know this study focused particularly on gynecologic cancers. Are there any specific considerations for this population and their caregivers?
I'm sure there are, and we're still trying to elucidate exactly what they are. I will say that what is interesting about this patient population is the data that exists looking at caregivers and other chronic illnesses, notably patients undergoing dialysis or other chronic, like dementia, Alzheimer's, so other chronic illnesses. There's a lot of data, the caregivers in those populations. What's different about our patient population is our patients are exclusively individuals with gynecologic cancer, so mostly female or women. That means that a lot of the caregivers are their spouses, so males. In a lot of the other literature, the caregivers are predominantly female. And so this kind of flips it around and looks at the caregiver role in a little bit of a different light than maybe in some other studies. So that's kind of one unique thing about our patient population. The other unique thing that just exists through for a lot of these quality of life studies in gynecologic cancer is that a lot of patients and caregivers hesitate to talk openly about gynecologic cancer because gynecologic cancer is still kind of a topic that maybe people don't feel comfortable speaking about with strangers. They hesitate to talk about, the fact that they have cancer of their uterus or the vagina or cervix or ovary. And so this hesitation to sometimes talk about these topics because they're considered, embarrassing, can sometimes spread to the caregivers. And so the caregivers have a little bit of stress because they don't even know the best way of explaining this type of cancer to other people if they might ask. So a lot of this is the role and the experience of the caregiver for a gynecologic cancer patient population can be very different than in other cancers or other chronic illnesses.
Definitely. There's definitely some unique factors I hadn't thought about. So for this study, how did you and your team go about designing it, and what were you investigating?
So we wanted to know what the distress level or the strain was for the caregivers of patients with gynecologic cancer. So we devised a prospective cohort study of patients and their self-identified caregivers. The patients were starting a new treatment of chemotherapy. As I said, most of these patients were starting chemo for the first time, but there were about a quarter of the patients that were starting for a recurrent regimen, meaning they had already been through chemotherapy once before, but they had either recurred and needed a new regimen, or they had a change in regimen. But again, most of these patients were starting for the first time. So this was also the first time that the caregiver was experiencing chemotherapy with their patient. Um, we surveyed the patients and the caregivers at the initiation of chemotherapy and then 3 months afterwards. For the patients, we used the NCC and distress thermometer because that was already being collected in clinic. So it's a very easy measurement tool to evaluate patients' distress. For the caregivers, we use something called the MCSI, or the Modified Caregiver Strain Index. This is a survey tool that has been mostly used in other disease states, but it does pretty well represent it pretty well measures the distress level of a caregiver. It has been used in other gynecologic cancer patient populations as well. For the caregivers, we also evaluated their social determinants of health, both at time zero, so at the initiation of chemotherapy, and 3 months later. This was really important to us because social determinants of health have a huge impact on how a patient both accesses treatment and gets through treatment, and then as a result can respond to treatment. Social determinants of health are all of the non-medical things in our life that can impact our health. So your environment, your education, and your socioeconomic status, just what you have knowledge of or access to, all of these things can impact how you interpret your health and then are able to access and proceed through healthcare. So we wanted to evaluate that for the caregivers because we recognize that caregivers are vital to getting our patients through their treatment. If the caregiver doesn't have the ability to get to the clinic, like they don't have a car, then the patient isn't going to have a car to get to the clinic. And so you have to ask these SDOH metrics of the caregivers as well as of the patients. So we did the survey, and we found a really interesting spread of demographics of our patients and as well as our caregivers. As I said, most of our caregivers were male. There was a pretty even split between those in different socioeconomic kind of domains. Though we did do a demographic survey of the caregivers just to get to know them a little bit better to begin with. We do have about a 40% Hispanic patient population, and that did transfer to about a 40% caregiver population. Most of our caregivers, 60%, lived with the patient, meaning they were a close family member or a lot of times a spouse. Over a quarter of caregivers also cared for others, meaning they cared for small children or older parents, or they had other caregiving responsibilities beyond the patient who was undergoing chemotherapy. A lot of our a lot of our caregivers still worked full time, which is notable because there are some resources for caregivers to take time off to take care of patients. But we did find that a lot of these caregivers didn't have, they might have been able to take time off of work, but they weren't paid for it. And so this adds an extra level of strain to this population that's already going through something that's very stressful.
Absolutely. Thank you for explaining the results. So what were some of the things that stood out to you the most with the results that the study found?
Yeah, so what else we found when we looked at these changes across time periods is uh, caregivers were very distressed as they were assisting their patients through chemotherapy. So at the time zero, caregiver distress was 42% of caregivers measured as like high distress or high strain. At the time three, so at the 3 month mark, 66% of caregivers measured as high distress. So this number went up over the course of time. Their scores of the distress scores increased significantly. And then their social determinants of health criteria, how many criteria or domains they met or screened at high risk for, those also increased from 63% at time zero to 87% at time three. This tells us that the caregivers are putting more into the care for their patient, and it's having a greater impact on the other elements of their life, such as food, transportation, housing, that are necessary for general living of life. And so this is having a lot of strain on our caregivers. What I thought was most interesting was that we saw caregiver distress go up. We saw it go from a mean score of almost 6 to a mean score of almost 10 on our index. Patient distress actually stayed about the same to maybe a slight decrease. So what this tells me is either we are appropriately addressing patient distress as they go through chemotherapy. We are asking them at every visit, how are you doing? What do you need from us? How can we help you? And then we are appropriately meeting all of those elements. And we're kind of counseling them as they go through chemotherapy. And we're potentially not doing that to caregivers. Or it means that the patients are kind of accepting everything as they're going through chemotherapy, and the caregivers are bottling it up, and they're very strained as the patient goes through chemotherapy, and they don't have an outlet for it. They don't have anyone asking them how they're doing, asking them if we can help them with anything. So I think it was this difference that was really striking to us, and tells us that there's a lot more work to do to address the needs of caregivers in this patient population.
Definitely. Those are very eye-opening results that shed some light on the caregiver experience. So in light of this, how can clinicians help to support and improve well-being for their patients' caregivers?
So I think it's really important to find out from patients who their caregiver is. So the way that we designed the studies, we asked patients to name one caregiver. Now, some patients have multiple caregivers and they just either pick one or say, I can't name one, I have a group, and that's fine. But find out from the patient who their caregiver is, and then make sure that you're asking that caregiver, ideally, because they're coming to the clinic visit, or maybe they're not coming to the visit, but maybe reaching out to them separately saying, hey, thank you so much for helping take care of whatever patient's name. What else do you need from us? Like, is there anything you need to help make caregiving possible or easier for you during this time period? I think acknowledging their existence and acknowledging the hard work that they're doing is really critical, and will offset some of the strain that they're feeling. We also saw, a pretty good link between social determinants of health needs and distress of caregivers as the patient goes through chemotherapy. So also, if possible, surveying or asking the caregivers what tangible items they need. Do they need resources for transportation, housing, food? What are the tangible things that they need in order to kind of live life as they're helping their patient through? Because a lot of those things will also translate to what the patient needs. So asking them what they need to help, again, navigate them to resources. So we've actually received subsequent funding for kind of the next phase of this study, where we will continue to survey the strain or distress of caregivers and patients, as well as evaluate their social determinants of health, and then go one step further and provide personalized navigation based on those responses. For this study, we had a handout that was made by myself and our nurse navigators and social workers, that we gave to our patients and caregivers, that gave them several resources in the area where they could go themselves, to, if they needed tangible resources, or if they just needed kind of psychological help during this stressful time. But we're translating that to hopefully be able to be a little bit more automated, a little bit more personalized, so that we can really help patients and caregivers, and then hopefully design a system that other institutions can take on, so that other caregivers can have also access to resources, and we don't see this increase in distress as the patient goes through chemotherapy.
Absolutely. It's wonderful to hear about this next phase of the study. Looking forward to hearing more about it as it unfolds. It's awesome. As we wrap up today, do you have any parting messages or take-home messages from the presentation you'd like to share with our audience, both clinicians and caregivers?
The only thing that I would say is that what has struck me through this process, as I've presented our findings now in kind of in various phases a couple times, is the number of patients and caregivers who have come up, even if they're not about like part of the study, have come up to us and thanked us for looking into caregiver distress. That this is, I feel, a part of research in gynecologic cancer that has really not been explored to its fullest extent. And caregivers really appreciate being asked how they're doing and what they need. And so I think that the more of us we all recognize the role that caregivers play in caring for our patients, but the more of us that take that on and really thank them and ask them how they're doing, I think that our patients and our caregivers' lives will be vastly improved.
Absolutely. It's a great message to wrap up on. So thank you so much, Dr. Zamorano. First of all, for all this work and helping to help support caregivers and improve their experiences as they go through this journey, and also for coming on today to tell us all about this work.
Of course. Thank you so much for having me.